Nursing and midwifery malaria in pregnancy gynecology. Malaria in pregnancy. Introduction. Malaria is a febrile illness caused by protozoa known as Plasmodium. It ranges from mild disease to a severe life-threatening illness. Malaria infection during pregnancy is a significant public health problem with substantial risks for the pregnant mother, her fetus, and the newborn child. This is a disease characterized by fever and is the most common cause of pyrexia. In tropics, it is sometimes associated with rigors, causative organism. The condition is caused by a Plasmodium parasite, which is a protozoa and has 5 species: black small square Plasmodium falciparum, black small square Plasmodium malaria, black small square Plasmodium vivax, black small square Plasmodium ovale, black small square Plasmodium knowlesi. Plasmodium falciparum is the common cause of malaria in Uganda. Signs and symptoms. History taking. Mother complains of the following: nursing and midwifery malaria in pregnancy gynecology. On examination, the following signs are found: pyrexia and tachycardia, pallor of mucous membranes, jaundice may be present, rigors, splenomegaly and hepatomegaly. Investigations. Diagnosis may be confirmed by the following: 1. Rapid diagnostic tests. These are done by using rapid diagnostic test kits, RDTs, which detect the antigen produced due to the presence of malaria parasites in the body, and the result becomes positive. If there are no MPs, there are no antigens, therefore the result will be negative. NB RDTs may miss low parasitemia, which is common in pregnant mothers and are also insensitive to P. vivax and malaria. 2. Microscopic diagnosis. This involves microscopic examination of the thick and thin blood films for malaria parasites. 3. Hemoglobin level may be low due to destruction of RBC. 4. Urinalysis is done to rule out UTI, which has similar signs as malaria. Nursing and midwifery malaria in pregnancy gynecology. Pre-erythrocytic stage. The malaria parasite life cycle involves 2 hosts. During a blood meal, a malaria infected female Anopheles mosquito inoculates sporozoites into the human host. Sporozoites infect liver cells and mature into schizones, which rupture release merozoites, which infect the RBCS, changing to trophozoites. NB in P. vivax and P. ovale, a dormant stage hypnozoites can persist in the liver and cause relapses by invading the bloodstream weeks or even years later. Erythrocytic stage. Within the RBCS, trophozoites grow into schizones, which burst, releasing mature merozoites may invade other RBCS. This accounts for relapse, and then that cycle is repeated. Some parasites turn into gametocytes, that is, microgametocytes male and microgametocytes female. These gametocytes swim in bloodstream of man, ready to be sucked by female Anopheles mosquito. The blood stage parasites are responsible for the clinical manifestations of the disease. Life cycle in mosquito. The gametocytes, male microgametocytes and female macrogametocytes, are ingested by an Anopheles mosquito during a blood meal. The parasites. Nursing and midwifery malaria in pregnancy gynecology. Nursing and midwifery malaria in pregnancy gynecology. Nursing and midwifery malaria in pregnancy gynecology. Management. Maternity center. A midwife is allowed to treat simple and complicated malaria by doing the following: history taking. Note when condition started and ask if any medication has been taken for that condition. Social, medical history taken to find out where she stays and if she had frequent malaria attack on that pregnancy. Past and present obstetrical history and present complaint observations. These are taken to assess the condition of the mother and decide on management, e.g., TPR and BP. General examination. This is done to rule out anemia, jaundice, splenomegaly, hepatomegaly, dehydration, which are common complications of malaria. Abdominal examination. Done to assess weeks of amenorrhea and condition of the fetus. Note if there are any contractions. Rigor is managed depending on the stage in which the patient comes. Medical treatment. Nursing and midwifery malaria in pregnancy gynecology. Hematics, e.g., ferrous sulfate and folic acid, are given to prevent or treat anemia. Sedatives, e.g., phenobarbital T.D., as to help mother to rest and prevent contractions. If after 2 days of treatment there is no improvement, then the mother must be referred to hospital. For prevention, Fansidar is given in 2nd and 3rd trimester. Severe malaria complicated. The mother gets worse, signs and convulsions may occur, resulting into unconsciousness or coma. Histories, observation, general examination are done. Management of rigors. If temperature is high, a cold drink is given if patient is able to drink. If not, then Intravenous infusion is put up to prevent dehydration. Tepid sponging is done to bring the temperature down. Some bedclothes are removed and fresh air is allowed to circulate around the patient. When it is low, then a lot of drink is given depending on the patient's condition. Cover can be put to prevent shivering. If sweating covers are removed, then patient is mopped with a moist cloth. Bed linen is changed after the sweating stage. Nursing and midwifery malaria in pregnancy gynaecology. A detailed note is written and mother referred to hospital. Management in the hospital. Mild or simple malaria is treated as outpatient with oral quinine as in maternity. Severe cases. The patient is admitted on antenatal ward which is well ventilated. Observations are done and recorded. General and abdominal examination are done. Note fundal height and fetal heart rate. Doctor is informed. Doctor will examine the patient and order investigation. OIE, blood smear to rule out malaria parasites. This will be repeated when treatment is over to confirm that the disease is cured. O urinalysis to rule out UTI. O stool for over and cis. OHB to rule out anemia. Medical management. Quinine 600 and Gindextro 5% TDS in 3 doses. This may be continued for other doses if mother's condition does not improve. If there is improvement, the dose is complete with oral quinine to complete 7 days. Nursing and midwifery malaria in pregnancy gynaecology. Nursing care. Management of rigors. This will depend on the stage in which the patient comes. With diet, a light diet is given to promote healing. Encourage plenty of oral fluids. B. Fluids may be given in acute stage. Hygiene. Tepid sponging is done whenever necessary and bed linen changed, especially after sweating stage. Oral care is carried out and later other will be allowed to the bathroom. Observation. These are twice with emphasis on obstetric observations. A fetal heart rate. Doctor is informed when there is any abnormality. Care of bowel and bladder. Encourage plenty of oral fluids to prevent constipation and maintain input and output chart. When the patient's condition improves, she is discharged home. Advice on discharge. To attend antenatal clinic after 2 weeks. Prevention of anemia by clearing breeding places. Preventing mosquito from biting her. Nursing and midwifery malaria in pregnancy gynaecology. Effects of malaria on pregnancy. To the mother. High temperature causes discomfort. Anemia due to destruction of IBC. This predisposed to high maternal mortality and morbidity. Puerperal malaria. Cerebral malaria. To the fetus. Abortion. Prematurity. Low birth weight. Congenital malaria. All these complications occur due to the following. High temperature, since the fetal heart G-center is inefficient. The extreme temperature affect the fetus. Mechanical damage to the placenta leads to parasites passing through the placenta, invading the fetus. The parasites cause damage to the placenta due to blockage of blood vessels. The placenta becomes infracted and insufficient. Nursing and midwifery malaria in pregnancy gynaecology. Because of the above, there will be no space for emergencies. Congestion of the ward causes cross-infections. Draining family income. Children are deprived of mother's care. Country's economy is strained to buy drugs for people and failure to work due to sickness. Effects of pregnancy on malaria. Due to strain caused by pregnancy, malaria is common in pregnant women. Pregnancy lower resistance, so many attacks occur and are usually severe. Malaria will worsen any existing anemia by causing hemolysis. The placenta harbors malaria parasites, so after treatment they are released into the bloodstream, causing another attack. Pregnancy causes more stress on young prime gravidas due to the attack of malaria are more frequent. Prevention. Prevent breeding places. Cover all stagnant water with oil or soil. Clear bushes around home. Do not have plants with wide leaves near the house. Remove all broken bottles and pots which can collect water. Nursing and midwifery malaria in pregnancy gynaecology.